on to the next session, and that features echo in emergency. Our first speaker is Dr. Srivastava. He'll be speaking on echo in acute myocardial infarction. He is currently Associate Director and Head Non-Invasive Cardiology at the Fortis Escorts Heart Institute and Research Center in New Delhi.
Rick is just speaking for a minute. Rick, just go ahead.
Yes, we are launching now the Heart Health Kit. Your heart is in your hands. We wanted to do this at World Congress, where our best friends are. I want you to know how to get this at no charge. Go to my website, powertohealit.com. Click on eBooks and Manuals. Then you will see Heart Wellness Kit. Click Purchase, put in promo code BHARAT, and it is free, no charge, 55-page manual, 4 audio recordings, which are direct treatment. They're not educational, they're the treatment. And then it is free through month of September. After that, with same promo code, it's, I think, 300 rupees, 1/3 of the list price. Since heart disease is such the big problem in India, we want to make this available so cheaply. And of course, as I've said before, 10% of our worldwide profits will go to Dr. H.K. Chopra's foundation to fight heart disease in India. Thank you.
Thank you, Dr. Levy. May I request Dr. Srivastava to please step forward for the next 12 minutes for the deliberation. Ladies and gentlemen, we'll take up all the questions at the end by the chairman.
Thank you very much, Dr. Chopra, for having given me this opportunity to be here this afternoon. Now, I have broadened the concept a little, and instead of just acute MI, I have made it echocardiography in coronary artery disease. First and foremost is the segmental wall motion abnormalities. There is some 16 or 17, depending upon which code you follow. And what you have to see is gradedly whether there is a gradation which is from normal, which is about 1.5 times from the diastole when it goes into systole, and gradedly if it keeps coming down, there is an aneurysm or a scar which is a diastolic deformity which persists both in diastole and systole. Now, whenever you are doing a echo in acute coronary syndrome setting, where is the strength of echo? The strength of echo is not in finding out the positive predictive value, because the positive predictive value is hardly about 50% or thereabout. What are you saying? What you are strengthening is the negative predictive value. And when you see no regional wall motion abnormality, means that you are not dealing with a serious kind of a myocardial infarction. Number 2, amount of myocardium at risk can be calculated by a wall motion score index. If it is greater than 1.7, then you know for sure that the perfusion defect is greater than 20% at increased risk of complications. The problems of regional wall motion abnormalities are operator dependent, equipment dependent, and of course, if you are getting an obese patient, then the patient dependent issues exist. So technical caveats in assessment of wall motion abnormalities are most challenging. It's the limitation are obesity, thick chest wall, lung disease. Well, not going into that, let's see what are the advantages. When you do an echo, it is 40 to 60% patients presenting to ER with chest pain and later having confirmed MI have a non-diagnostic ECG. All of us know that. To circumvent this issue, the concept of troponins and biomarkers have come, but all the same, let's see where does echo stand. 70 to 80% patients with non-QMI present with ST depression only, and 80% of these will have a subtotal coronary occlusion. These are established facts. Echo provides new and useful information in 25, almost a third of the patients admitted to CCU. It is twice more likely to be useful in those who have had an echo in recent past, because once you have a comparative baseline in past, you can check it out for what's happening at this point of time. Echo can predict cardiac events in patients with chest pain. with a predictive events as much as 91% as against only ECG, which is 40%. This is echo triaging of ACS. I have deliberately kept the biomarkers, troponins, CPK, CPKMBs out of it, but if you find that there is an ST segment shift, if there is an ST segment which is unequivocal, well, admit the patient. But if it is no, then you can do an echo and find out whether to admit the patient or not admit the patient. This is as old as 1991. Unfortunately, what has happened is that most of the places echocardiography is not available 24 hours. Even if it is available, especially in the Western world, it is more expensive than the drops, and that's the reason why we echocardiographers have left behind, probably because the troponins being cheaper, readily available in a kit form, does not need too much of an expertise in the form of the nurse or the attendant, physician assistant can calculate that. That's the reason why in the triaging echo probably has been left out. Well, for sure there is some value of echo in diagnosis. Let's see what does it offer for assessment of prognosis. Increased risk of future events. Enough and more data is there that if there is an LV dysfunction which is lesser than 40%, there is worse problem. Extensive infarction with wall motion score index greater than 1.7, we know that 20% or greater or thereabout, the perfusion defect is there. If there is a restrictive mitral inflow, it's an independent risk factor of development of CHF and increased mortality. NLE enlargement and inducing ischemia on dobutamine stress echo, these are the issues which lead to future events. Echo provides a quick bedside specific marker of ongoing myocardial necrosis, evaluation of extent of jeopardy or necrotic area. However, resting echo overestimates the infarct size because several times a stunned myocardium or a hibernatic myocardium or a tethered myocardium will be not moving the moment you correct all these things. Well, if it is stunning, it will get improved by itself, but if you can correct hibernation and tethering by relieving the ischemia, you'll start finding that probably echo. However, it just shows that these are the patients at a higher risk. Let's see what all it can show as complications of myocardial infarction. You can look at the free wall rupture, VSDs, papillary muscle rupture, endocardium aneurysms. You can look at the mitral regurgitation, which could be because of LV dilatation, papillary muscle dysfunction, or papillary muscle rupture. You can look at the LV thrombus, tamponades, infusions, RV infarcts, LV outflow tract ulcer. Everything can be assessed, and certainly hemodynamic assessment bedside cannot be done better than with an echo. These are certain examples. Here is a ventricular septal rupture in an acute MI setting. This is yet another example of an acute myocardial mitral regurgitation in a setting of an acute coronary syndrome. This is the most dramatic. All this patient gave us time was to do an echo and then he died. This is a cardiac rupture, and of course here is LV aneurysm with a thrombus, layered thrombus, which can be picked up very comfortably by an echo. Aortic dissections, I am not talking because I understand Dr. Kapoor is taking a full lecture on this. I'll skip on that. Pulmonary embolism, pericardial diseases, these are all things which can be eliminated by doing an echocardiography, and hence non-ischemic chest pain evaluation, the first line of code of investigation should be an echocardiography. Now these are certain niche areas for echo in CAD. Diastology. Look at that. Mitral Doppler inflow pattern, pulmonary venous flows, and you know the prognosis. You can calculate the pulmonary artery other than the diastolic dysfunction, which in itself are diagnostic for shortness of breath, diagnostic for what's happening in future, prognostic indicators. Also, you can get hemodynamic information by calculation of pulmonary artery systolic pressure, pulmonary artery diastolic pressure. You can calculate the left ventricular end diastolic pressure using the tissue Dopplers, thereby indirectly measuring the pulmonary artery wedge pressures. Left ventricular diastolic dysfunctions, cardiac output, stroke volume, LV contractility, IVC, hepatic vein flow, everything can be measured by an echo. As far as viability is concerned, there is no data to suggest that you should revascularize a non-viable tissue. If you revascularize non-viable tissue, you do more harm than doing good, and it is more than anything else. It's a cost which people incur, and it's unethical. How do you decide that? This is one data which said that if you revascularize patients without viability, they are the worst. So it's better to leave them without revascularization rather than to revascularize them with viability. Here, this is where the dobutamine echocardiography figures a positive predictive value of reasonable 83% and a negative predictive value of 81% or thereabout is available in enough and more studies. This is how you do it. You do it at rest, low dose, peak dose, and what you find is a apical apical septal area, which shows certain quantum of stunning, which can improve subsequently without revascularization. More examples. Here there is an LV dilatation which you can see on the low dose and peak dose. The lateral wall becomes almost hypokinetic to akinetic, suggesting that there is a reversible ischemia element on the peak dose. This is probably the best kind of stress echo you would want to see, that the moment you start giving dobutamine and there is the LV cavity gets so chinked, because these are the patients who have got an ST, excellent prognosis regardless of what the ST segment changes in the ECG occurs. This is chinked LV, and these have got very good prognosis. The Achilles heel was assessment of the contractility, whether it is hypokinetic, whether it is akinetic, and to counter that, several things have come and they have gone out of phase as well. One of them I just wanted to highlight here was color kinesis. With every 30 milliseconds of inward motion towards this LV cavity, the myocardium keeps changing its shade. You can utilize this to add more objectivity towards assessment of the wall motion abnormality. Myocardial contrast echo has come in a big way, and you can find out the areas of perfusion or non-perfusion depending upon the occlusion of the coronary arteries. Not only that, if you're lucky, you can see the coronary arteries directly. Here is an example of a left coronary artery. Dr. Nanda was there in our hospital a few days back, and he demonstrated so beautifully the coronary arteries in a kid. But you may not be so lucky all the time. But you can see the flows, you can calculate the flows, and you can see not only that. Here is an example. T is much better to see the coronary arteries. Not directly related to the talk, but IMA duplex scanning is something which is very interesting. You can find out what's happening to the flow of the internal mammary artery. What you can do is you can ask the surgeon to occlude the coronary arteries, and you can see it from the left suprasternal view, what's happening to the IMA graft. And this is the graft the moment it is functional adequately. The diastolic flow is much larger than the systolic flow, and that's how you know that the IMA graft is functional. Aortic atheromas are fascinating things, fascinating for us as echocardiographers, but you can use them to monitor. I'll just show you an example of an aortic atheroma. This is a huge, big protruding atheroma, which was incidentally found. Now, the clinical implications of finding an atheroma on incidental finding is it can explain you unexplained stroke, peripheral emboli, embolization during invasive procedures like cath and IABP insertion. You can choose where to insert the grafts. You can find out, so the risk of perioperative stroke during an open heart surgery can be modified, or if not eliminated, certainly. Modification of surgical techniques during CABG to prevent embolization from the aorta can be done. The cannula you can use can be the shorter size, and you can avoid the place where there is an atheroma. I'm just mentioning this again, that not only is it useful for coronary artery disease established patient, but you can use the same machine to find out carotid intima media thickness and brachial artery flow mediated dilatation for the endothelial dysfunction, and these are certain things which are extremely useful in preventive cardiology, which is the focus of the meeting this year.
I'm sorry for the interruption.
Just finishing, So this is my last slide, that in echo in emergency room you can detect size and site of the infarction, you can assess prognosis, you can see associated cardiac defects, detection of complications and effect of therapy. Thank you very much for your patient listening.
Thank you, Dr. Srivastava.